Hello, good morning, good afternoon, and good evening to our distinguished speakers, chairs, and audiences of the ACNS webinars in different parts of the world. We are back again with yet another session of ACNS webinars just for you. The speaker for the first session of today is our very honored guest from China, Professor Vigo Chow. Professor Chow is the Professor and Chief Neurosurgeon in the Department of Neurosurgery at the Ruijin Hospital, Shanghai Jiatong University School of Medicine, Shanghai, China. Professor Chow is the Vice Chairman of the Shanghai Neurosurgical Society, and he is Executive Committee member of the Chinese Society of Neurological Surgeons. He is a co-committee member of the Asian Congress of Neurological Surgeons. He is a noted author and is also a member of the editorial board of several peer-reviewed journals. He is the founding chairman of the Asian Congress of Microvascular Decompression Surgery. We are extremely honored to have him today with us to be a speaker at our webinars, and today he'll be talking about microvascular decompression in cranial rhizopathies, hype or hope. The second speaker for today's session is our honored guest, also from China, Professor Ming Li. Professor Ming is the Associate Professor at the Department of Neurosurgery at the Henan People's Province Hospital, Henan, China. He is Associate Editor-in-Chief of the journal Cancer Translation Medicine. He was a former postdoctoral research fellow at the Neurosurgery Department of Massachusetts General Hospital, Harvard Medical School. His research is focused on exploring new methods to improve diagnosis and therapeutic evaluation of brain tumors. We are extremely honored to have him today with us to be a speaker, and he's going to talk about immunotherapy in gliomas. The chair for the first session of today is our honored guest from Brazil, Professor Hildo Azevedo. He was the chairman of the Department of Neurosurgery and chief of residence program, the Hospital da Restauração, Recife, Brazil. And he is also the full professor of neurosurgery and chairman of Department of Neurological Surgery at the University of Pernambuco, Recife, Brazil, since 2000. He was the past president and vice president of the Brazilian Academy of Neurosurgery. He was the past secretary and the first vice president of the WFNS, and was later nominated as the honorary president of WFNS in 2017. He has been decorated with several medals of honors for his contribution towards neurosurgery in his country, and we are extremely thankful to him for accepting our invitation to chair the session of Professor Vigo Chow. The chair for the second session of today is our honored guest from Japan, Professor Kazuko Kurosumi. Professor Kurosumi is a professor and chairman in the Department of Neurosurgery, Hamamatsu University School of Medicine, Shizuoka, Japan. He is a prominent member of the Japanese Society of Neurosurgery as well as member of the Japanese Society of Gene Therapy. He was honored with several grants and awards in his illustrious career, namely the Journal of Gene Medicine, Japan Society of Gene Therapy, Young Investigator Award, American Society of Gene Therapy, Travel Award, and Japanese Society of Neuro-Oncology Hoshino Award. He is a prominent author and has published several manuscripts in various peer-reviewed journals. We are extremely honored and thankful to Professor Kurosumi for accepting our invitation to chair the session of Professor Li Ming. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the distinguished audiences to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to our first chair, Professor Hildo Azevedo.
Good evening, you, my friends in Japan. Good afternoon in Europe, and good morning here in South America. It's again a great pleasure to be joining the ACNS education program. I think my icon in neurosurgery, the icon in neurosurgery, Professor Yoko Kato, who promotes education. And I think that for us professors, education is the only way that you could put this small world together, and you could somehow decrease the problems that we face in this troubled world today, I'm afraid to say. So today we are going to analyze one of the most challenging and difficult to understand clinical relation between the cranial radiculopathy, which most of the time they produce pain, and related to the so-called microvascular conflicts. I understand that is a very, Professor Zhao, that's a very disputed issue, which been along 50 years or more, have been raising a lot of questions. So my former mentor in England in the 70s and 80s used to say that you should be always very skeptical about what you hear, what we see. So when we see that these kinds of neuralgia, mostly, that they produce perhaps the most dreadful pain that we have in our lives, in our neurosurgical lives, I still record a couple of patients that was actually with a revolver in their hands, trying to kill himself because of trigeminal neuralgia. So it's a dreadful situation. And there is no bearable pain. My former boss also used to say that only bearable pain is the pain of someone else. So that's in our life, what we need mostly is to treat pain. And today we are going to have the fortune to hear Professor Zhao's concepts about microvascular compressions, and of course, the clinical findings induced by these compressions. So on the other hand, we need to understand that along the years, we have so many treatments for us to treat this kind of so-called trigeminal pain and other things caused by vascular compression, that you could try to put together whether microvascular compression affecting those nerves are the sole cause of this cranial neuropathy, which in the end, they come to induce pain. So, Professor Zhao, I'm very anxious to hear, to learn from your concepts, and later on we can discuss how we could put together to match the clinical findings that we have, the operative findings that we see, and the outcome of the patient with this kind of, in later instance, how the decompression can actually induce pain relief and other problems that these conflicts might induce. So, Dr. Raj, again, many thanks. I think that we are going to be having an absolutely fantastic session, because also, on the other hand, it's not my topic, but immunotherapy in brain gliomas is one of the most novel issues that you can fight this also most dreadful disease. So let's participate of this wonderful session that I was fortunate to be included to be on it. Thank you, Raja. Thank you very much. My extend, please, my gratitude to Professor Kato. Thank you very much.
Thank you very much, Professor Azevedo, for your very nice introduction. I'm sorry. Good evening, professors and participants. It is my great pleasure and honor to deliver the lecture on this webinar, to meet my friends, colleagues all across Asia. Although COVID-19 pandemic prevented us from meeting face-to-face, meeting person-to-person, but however, we can still meet face-to-face on this virtual meeting. ACNS, Asia Congress of Neurological Surgeons, was initiated by late Professor Kano, and now is under the leadership of Professor Kato. ACNS is committed to promotion of neurosurgical continuing education for young neurosurgeons in Asia. I think the mission is of great importance. I'm proud to share my experience with you, and my talk is based on my personal experience of more than 6,000 MVD operations. Although this is a huge number, the case volume is astonishing, but considering the fact that China is a #1 populated country, so we are very happy to be able to operate so many cases. Today I will talk about MVD for cranial rhizopathies. The operation booming in recent years in China, but still their problem exists. So I will deal with this kind of phenomenon particularly. When we talk about MVD surgery, we have to remember that those who pioneering the operation, although we know that Walter Dandy found that new plasma and vessel nerve contact may cause trigeminal neuralgia, but it was not until Peter Janitor who systematized the operation and later became so famous as MVD. In 2009, in the 14th WFNS meeting, I witnessed a scene, as you see this picture, that 3 president of WFNS, ex-president, present, and president-elected, they come together to deliver the honor, the medal for Peter Jennett. I think he really was such kind of glory. The concept of cranial rhizopathies. We all know that the mechanism is about demyelination of the axon, overexcitation, and hyperfunctioning. So concerning etiology, we know that nerve vessel contact, inflammation, neuroplasm, and anatomical anomaly may contribute to the symptoms. These kind of cranial rhizopathies, mainly hemifacial spasm, trigeminal, glossopharyngeal neuralgia, these are a definite indication for MVD. But still, there are some kind of disease like tinnitus, muscle spasm, torticollis may have something involved in the mechanism of nerve vessel contact. But definitely, microvascular decompression indication is cranial rhizopathies, as like hemifacial spasm, trigeminal neuralgia, and glossopharyngeal neuralgia. We talk about cranial rhizopathies. It not means cranial nerve disease, because cranial rhizopathies emphasize the pathology that it's located in the root of respect nerves. So cranial rhizopathy is a good term, I think, to describe such kind of hyperfunctioning cranial overexcitation, which cause the symptom of hemifacial spasm, trigeminal neuralgia, and glossopharyngeal neuralgia. For MVD, it's a functioning operation. The patient usually have very high expectations because they suffered this very long time, and they have received different kind of treatment. But all these treatments failed. Finally, they come to neurosurgeon to help. For successful cases, they call it magic operation. They can relieve the symptom we suffer patient from years or even much longer. In my case, the longest history of hemifacial spasm is for almost half a century, you know. So when they relieve the symptoms, they think it's quite a magic operation. But still, there are failed cases. The patient suffered physically or economic loss. And if the complication occurred, that will be a kind of catastrophe for his or her life. So we have to maximize the cure rate and minimize the complication. So we have to make balance, the effectiveness over risks. So every neurosurgeon, when you start MVD surgery, you have to think about this. And we also take it into consideration that individual and anatomical variation exist, which makes MVD surgery from very simple to extremely complicated. And MVD surgeons are very happy because they can collect huge case volume, like in China. For myself, I have personal experience of more than 6,000 cases. This is a big cases, but I cannot say this is the largest personal volume, because in China, there are still some doctors make much more operations. As the case accumulates, the risk and complications accumulates. So we have to pay high attention to all these things. Some misunderstanding of MVD surgery. The patient usually say they think it's minimally invasive surgery, but it's not equal a small surgery. The patient have to take the risk of general anesthesiologic condition, craniectomy, and many others. Anatomical variation exists, which make MVD surgery very easy to extremely complicated. And complications like cranial nerve palsy, hemorrhagic, ischemic, or even mortalities exist. The neurosurgeon, when you start MVD, you have to ask all these questions. Whether number one is whether the diagnosis is correct or not, whether it is true hemifacial spasm, trigeminal neuralgia, or glossopharyngeal, because you have to make some kind of differential diagnosis. For example, in case of hemifacial spasm, you have to make differential diagnosis with Bell's-Tick, peripheral spasm, major syndrome, habitual tick, or even dystonia. For trigeminal neuralgia, you have to understand whether it's a typical or atypical, or whether this is just a neuropathic pain. If you will take all these cases into MVD surgery, then the results may be optimistic, So we have to understand the etiology before making operation. We have to understand where the culprit vessels coming from, the source and root, or even tumor origin. And if the patient tolerable to MVD surgery, and we have to stand in patient's situation that we have to consider is MVD is best option for the patient. So these questions we should take all into consideration before we take the measure of MVD surgery. MVD do's and don'ts. First, we have clear diagnosis. It should be precise, and we have to take anatomical variety in mind, and we have to do proper case at right time and leave high risk case undone. This is very important for those who tried MVD surgery at initial stage. So if you think it's very high, you just leave the case to the matured, skilled hand. Diagnosis. It is quite easy to make diagnosis of hemifacial spasm. See the patient, the left side, you feel the involuntary contraction of the facial expression muscle. Where it's getting severe, she not even open his eye. So the diagnosis is easy, I think. For trigeminal neuralgia, the patients usually the very painful appearance. The so-called the severest pain of a human being ever experienced. It's called trigeminal neuralgia. And when we make differential diagnosis, we have to pay attention to such kind of things. For example, peripheral spasm. It should not be misdiagnosed as bilateral hemifacial spasm. Some doctors think this is a bilateral, but I don't think so. Because one thing you have to make differential diagnosis, if this is a bilateral hemifacial spasm, it should develop one side and the other side, but not occurred at the same time. So this is obviously peripheral spasm, And much severe, called major syndrome, is Cranial dystonia, and the patient suffered it very painful, and it called their life very hard. And for this 7-year-old boy, he went to other hospital, and the doctor about to make operation for him, but his parents come to consult me for the diagnosis. I see this is not a hemifacial spasm. It's a habitual tic, because for young boy, it is not, it is almost never seen such kind of things happen in just a 7-year-old boy. So I see no operation is indicated. So if his patient, his parents didn't consult me, then the patient may be the victim of operation. And this is a Bell's tic. The patient have a left side facial palsy for 2 years, but he have the residual symptom of synkinesis when he close his eye, then he will have symptoms and contraction of the affected face. So this is very obvious like this. So this is Bell's tic. We cannot make operation in this patient. In the literature, we see MVD ambiguous results. The effectiveness vary from 70 to 100%. But I have to ask whether this is how about the case volume and learning curve? MVD for skilled hand or just a beginner, they have different successful rate. So how to evaluate the successful rate? Whether this effectiveness is immediate or delayed improvement, or there is a fluctuation. And how about long-term follow-up, 5 years, 10 years, or even longer? How about recurrence rates? I think the result is far from satisfactory. And still there is complications, cranial dysfunction, CS leakage, infection, or even hemorrhage. So we have to take all these into consideration. And this young lady have been operated in other hospital. 3 months later, she come to my clinic, and she compared the right side facial palsy and the right side deafness. She just asked me to see if there is a remedy for repair of this defect. But I say it's no, maybe this is a damage due to immature technique for this patient. So these kind of things we see not very often and not very rare. We see such kind of complications in other hospitals have been made. So significance of image studies, I think it's very important because it helps to understand MVD, which should be done or should not be done. Whether there is a culprit vessel, the source and root, compression site, the artery is coming from SCA, ICA, PICA, VA, or even neoplasm. And surgical difficulties, we have to understand the anatomical variation, vascular complexity, size of cistern and fractures, petrosal endostosis, etc. All these factors will influence the difficulties of operation, sometimes make the MVD difficult or even inapplicable. So we have to understand all these things beforehand. And for example, these are left side hemifacial spasm patient in his 50s. On the picture on the left side, you see the system is very small, while on the right side, the system is big. So if we deal with the patient like this, we have to take into account that during operation, maybe it's very difficult to release the CSF. So we have to drip mannitol beforehand, before we open the dura. So these measures we have to take. And MR virtual endoscopic simulation view, we can see that the 3D structure is almost the same we found during operation. And this is a vertebral artery, this is basal artery, this is the fifth nerve, and this is artery which compresses the root of trigeminal nerve. Like this, it's almost the same. You know, this is the VABA. We push it away, and then we see the compression side is like this. It's almost like what we see on these 3D images. So preoperative image study is very important to help us understand the intraoperative dimension. And this is right trigeminal neuralgia. The picture shows that there is a SCA compressed trigeminal nerve, and there is still an atrophy of the nerve. During operation, we see this is a trigeminal nerve. On the root of trigeminal is very, you can see the very opposite atrophy of the nerve, and this is the offending vessel. So these pictures help us to understand what we can see during operation. And this is a left side trigeminal nerve. We see the loop of SCA compressed medially on the nerve. If we make move of this artery, the surface decompression can be achieved. And we also published an article, and we summarize that before operation, if we see that there is an artery compressed vessel, compressed trigeminal neuralgia, that is a good indication for good outcome. And usually we take such kind of 3D fistal and 3D TOEFL image. And on these images, we can see the artery compress the facial nerve, and we make the reconstruction of vasculature. We see this is the ICA and this is pica. MVD technique involves the preparation, position, incision, and bone window placing, cranioplasty, and approaches. We will elaborate these points later on. Hair preparation, and usually those limited areas have been shaved, and these make the prompt and speed recovery and little cycle effect for the patient. So after operation, the patient can return to social work quickly. Incision is hidden in here, and there's no cosmetic effect, like this one, like this one, like this one. So the incision is hidden within the hair. Operation begins from placing the position like this, and you see the picture that the patient is taking a lateral position, and he has been restricted by this kind of restrict band. And nowadays, we have used such kind of restriction band to secure the patient position very good, like this. Skin incision and bone window size and position, we have to write all these transverse sinus, sigmoid sinus, and for Trigeminal, the bone window is in this area, and for hemifacial spasm is quite different. It should be near the sigmoid sinus, and even for CPS tumor, we use such kind of bone window. So we use this straight line incision and can fit for all kind of operation in posterior fossa. And bone window, how to make a bone window, and after operation, you have to make the cranial plasty. And this patient come for us for a failed case of MVD, where we make 3D CT like this. We see the bone window place is not good. It's much higher. It should be much lower like this. And sometimes the patient having operated like this, leaves the bone window unrepaired. This may cause the CS leakage, infection, and inconvenience, uncomfortable for the patient. And in our case, in our series, we all do this kind of bone window and make the cranioplasty completely. And the closure of dura, we should do it a watertight suture like this. And if we don't do this, the CS leakage occurrence should be high. MVD zero retraction technique, we don't use 3-pin fixer. I don't think it's necessary. In all my cases, we don't use it. No self-retractor applied. Different size of cotton strip used to facilitate CS release, cerebral protection, and exposure. Like this, our nurse can make different size of cotton pad for us to use. So I think these are very important, and very small instrument, very fine instrument, bipolar, dissector, pincet, suction tube. These are specially used for MVD surgery. And surgery cell, the different size of surgery cell, our nurse prepared all these for us with meticulous handling the different type of copper vessel. We see ICA, PICA, VA, and a VA plus multiple arteries. Of course, the easiest is ICA. And in case there's some kind of artery loop is very complicated, like this. He wraps the facial nerve very firm with adherent to all these nerves. So you have to make mobilization and decompression with care. MVD for hemifacial spasm, we have different approaches. The operator nuance like number one, we have paracerebellar approach. These are very simple and account for about 60%. And we have paracerebellar infraflocculus approach, which account for 23%. And we have paracerebellar infrachoroidal plex approach, which account for 16. So the easiest is about this one, and these are a little bit complicated. For example, when we adopt paracerebellar approach, it is very easy to expose the offending vessel like this. And this is paracerebellar infraflocculus approach, because the flocculus in this patient is very huge. So we have to dissect the cerebellum flocculus and number 9 and number 10 nerve slit. So we have to diet sharply without any damage to the glossopharyngeal nerve or vagus nerve. So sharp dissection is very important, because the ninth nerve is very vulnerable. If it is being damaged, there will lead very severe complication of low cranial nerve symptoms like hoarseness and difficulty in swallowing. So we have to dissect sharply until to the root of the nerve. So if we free the flocculus, then we have make coagulation and make shrinkage of the bulging flocculus. So then we can gradually exposure, make gradual exposure to the corporal vessel and the root of facial nerve. So in this case, the surrounding arachnoid trabeculae is very thick. So at this moment, we nearly reach the target. We found a compression artery, a compression site, like in this area. So we dissect, make 4 dissects of this arachnoid trabecule, and then make 4 mobilization of the offending vessel. And the offending site is around this area. Due to time limit, we have to skip the video. And this is a paracerebral infrachoroidal plex approach. When we adopt a paracerebral approach, we can see this area like this. But if we want to see the far deep located offending vessel, then we have to adopt the paracerebral infrachoroidal plexus approach in this area. So even though this is the same patient, the different angle of approaching makes a different view. Different vessel, we have to use different technical decompression. Like this is ICA. You can see obviously this is a dent of a compression site, So we make the compression in this area, and this is VA plus ICA, and after compression, we put the prosthesis under the VA and ICA, and this is pica. Like this is obvious dent of the compression site So we make the compression like this. And for repeated cases, we have encountered several cases that are being operated somewhere in other hospital, and we see that the previous operation had been not done properly. Like this one, the process is put in this area and leave the real compression site undone. So this may be due to poor technique and not experience with operation in this case. So the real operation compression site is this, but the previous operation, they make the processes in this area. For patients, before operation, we have to take the picture. And for these cases like this, we see this is a pica compression. And but during the first case, initial stage, the operation at this stage, you see this ica very close the facial nerve. So if you are not experienced, you will think this is a offending vessel. But actually, it's not, because on the image study, we see that it's coming from the pica. And even after we make the decompression of ica, but intraoperative monitoring says that lateral spread response still exists. So we make further dissection and we found the loop like this. This is an approach called pericerebral infrachoroidal plexus approach. You see choroidal plexus is here, and the artery is a pica, and this is ica. So pre-operative image tell us there is a pica compression, and intraoperative monitoring also tells that if we make mobilization of this compression site, there's still lateral spread response exists. So after the lateral, so for fear that later on the ica will still compress the facial nerve root exit zone, so we put these kind of processes in this area. And after operation, the symptoms is gone away. Clinical value of intraoperative monitoring, we now use it for the difficult case, for reoperative case, for hearing preservation. And I don't think it's a must for skilled hand of MVD doctors. Lateral spread response didn't raise tick cure rate. And we have the paper published in Journal of Neurosurgery, and we think through this kind of controlled study, we see the value of intraoperative is less. And before operation for hemifacial spasm like this, the patient has more than 10 years hemifacial spasm history, but after operation, immediately the patient has completely relieved the symptom like this. And patient is the very strong symptoms, and after operation, the patient is free from symptom and no any other complications. And this is the goal we try to achieve. And here I would like to show you the case and show a patient consult me. She tell me that she is so pain that she cannot talk to me. So she writes down all these words to me. This is a surgical scenario from an unlucky lady, so from Trigeminal Neuralgia. She had been operated in 2008, but after 2 years, she recovered. And in 2014, she received a percutaneous radiofrequency thermocoagulation, but 6 months later, there's a recurrence. And the doctor suggested him to receive a gamma knife, and after gamma knife, there is some effect, but still there is a recurrence. And the patient received balloon compression, and after the balloon compression, she feel the swelling of his face, and the pain is so severe that he cannot even drink water, eat, and the pain is so severe that the medication is totally ineffective. The patient suggests she further receive radiofrequency thermocoagulation, but there are still symptoms. So the patient come to me, see if there is any good measure to rescue him. So considering all these kind of surgical treatment adopted, the patient, they are not still satisfied. So from this case, we know that even though for trigeminal neuralgia, there are so many treatment choices, but still the patient is not satisfied. So we have to admit there are still symptoms we cannot complete cure. And later on, the patient received the second Mvd surgery, and his symptoms gone away, luckily. In Mvd surgery for trigeminal neuralgia, we have to avoid to make the process, put process just between the compressed side of nerve. So like this patient, during operation, we see the artery like this. We dissect it completely and see the artery underwards. It will stick to the nerve and make compression very severe. So like this, and there is a adhesion site in this area. We have to mobilize the artery in this way, avoid any damage of the artery and nerve. So we have to dissect small bit by bit and put the process not in the site of vessel nerve contact, but just on the distal and lateral part, and to make decompression of bridge type. You can see this artery, this is a branch, and the deep, very severe adhesion is here. We dissect, sharp dissection, and make the kind of decompression like this. So we put the process here and here, and leave the previous compression sites free from contact of processes. And speaking of recurrence, I think the mishandling and technical immature may cause this kind of recurrence. For example, in this case, we can see there are a lot of processes here. We have to remove all these processes, and it's really a time-taking operation, and we have to take all these processes with meticulous care and not damage any nerve and vessels. We dissect and remove all these processes adherent to the nerve, and then we find the underwards vessel which compress the nerve. So maybe the first operation having handled improperly and missing the Culprit vessel here like this. So we make full dissection and recognize the real Culprit vessel and make the decrease again. And in the past 25 years, having operated patients, these are all my personal series. So, you know, that actually up till now, it's more than 6,000 cases. And we have made a Gbm analysis, and for the volume of more than 4,000 cases. For hemifacial spasm is much more case, and they seem to look better results, long-term relief than Trigeminal. Trigeminal goes like this, and hemifacial like this. And average speaking, the long-term effectiveness is around 87%. How to do the operation for glossopharyngeal neuralgia, whether the glossopharyngeal neuralgia or even vagus nerve should resect. In the literature, they see when they adopt glossopharyngeal neuralgia resect or vagus resect, they will cause pain-free more than 90%, and they have complication up to 35%. Permanent complication 25%, and they will cause difficulty in swallowing, hoarseness, and something like this. So whether this is really needed. In the literature, we see, for example, they see this is a glossopharyngeal nerve, this is a vagus nerve. And they cut the nerve here, and like this, they even cut the glossopharyngeal nerve and several rootlets of vagus nerve. They think it's effective for the treatment of glossopharyngeal neuralgia, but I don't think so. In my cases, more than 60 cases of glossopharyngeal nerve, we never cut any glossopharyngeal nerve. For example, like this is a pica compressed to the rootlet of glossopharyngeal nerve, and we make compression like here. We leave the nerve complete, and not even one case we cut the glossopharyngeal nerve or even vagus nerve like this. And this video shows how to make a decompression for the glossopharyngeal neuralgia. And before operation, MRTA shows there is a low cranial nerve. And during operation, we see that the adhesion of arachnocoronal plexus to the glossopharyngeal nerve or vagus nerve. So we dissect sharply with this kind of adhesion. So we later on, we moved forward and we cut all these adhesion coronal plexus with very fine bipolar, and we cut all these adhesion. And then we see the artery behind. Behind we see, we see the artery compress the nerve root of 9th and 10th. You see here, like this, Culprit vessel, we find it. And we make full mobilization and compression, and the patient's result is quite good. And I think for glossopharyngeal neuralgia patients, the result is much better than trigeminal neuralgia. In my series of more than 60 glossopharyngeal neuralgia patients, the immediate relief is 100%. And similarly for Mvd approach 100% cure, generally speaking, is still legendary. So patient satisfaction is much more important than doctor's so-called success rate. And Mvd surgery needs experience and patience. Even though operation carry risk, but it could be controlled minimum by skilled hand. So technical and academic exchange is very important and beneficial for the popularization of Mvd surgery. For this kind of patients, the patient shows is very painful before operation, but after operation, she's lucky. You can see the smile of the patient. I think it's a best reward to our doctor. On the follow-up, the patient is completely symptom-free. And in regional hospital, we have a Mvd group, and we operations around 400 or 500 cases a year nowadays. And we started Mvd conference in Asia in 2016 in Shanghai, and to promote the education and the technical exchange. And we had second in Japan, Kanagoe in 2018, and we have third in Busan, Korea in 2019, and recently we had fourth Asia Conference Mvd Surgery. This is a virtual meeting called by Chinese Taipei. So MVD aiming at 100 cure and less complication is still a long way to go. We have to remember, we have noticed that the doctor showed epitaph that we can cure sometimes, to relieve often, to comfort always, because we should always with humble to handle the patient, to bring the best or biggest benefit to the patient is our aim. So thank you very much for attention.
Thank you very much. Professor Hildo can make a short comment before we move on to the second lecture.
Yes, Raj, I understand that you are running behind schedule. First of all, I would like to congratulate Professor Zhao for his absolutely fantastic experience for your absolutely fantastic, skillful technique, and also for his philosophical concepts and advice to the young neurosurgeons. What's about to treat patients and how to proceed with our profession. So we must understand that, first of all, what we have along the many years since Hippocrates, that we need just to relieve pain, you need to treat patients, and first of all, to make no harm. And what Professor Zhao stressed, that this is a functional surgery, and as being a functional surgery, your complication rate should be very small. You should send back our patients completely free of pain, of course, and completely free of new symptoms. So what I advise is an education course. So if you wanted to go and to do these techniques, you should go to expertise like Professor Zhao, and learning and understanding from him how he proceeds with his operations, because we cannot take the data of Professor Zhao and using this data to co-validate our indications as a young neurosurgeon, because you might not kill the patient and you might add a lot of new symptoms. That's what Professor Zhao did stress very much. I think that is the most challenging. We have no time.
Can I ask a question, Professor? Can I ask one question?
Yes, of course.
Please.
Okay.
Oh,
yeah. Professor Shao, that's a great lecture. One of the super lectures we have ever heard on this forum. Some questions to you. One is, do you ever consider vein as a culprit for this neuralgia? Vein, you told about all arteries, because there are so many publications where people stress that veins can also be a culprit. And you started very clearly, an abnormal anatomy can make a simple surgery very difficult. That was an excellent statement. Have you ever had a persistent trigeminal artery as a culprit for trigeminal neuralgia? And the other thing is vein. Vein, could it be a culprit? Because many publications I have seen. And do you sacrifice petrosal vein ever for trigeminal neuralgia surgery? If access to, if access to separate the superior cerebellar is difficult, do you sacrifice petrosal vein? These three questions, Professor.
Okay, very good question. And these questions have been frequently asked by the doctors. Yeah. And first question about the vein, okay, involved in the Mvd surgery. For trigeminal neuralgia, there is a case that the artery is adherent to the vein, and the percentage is about maybe account for 10 to 20%. Unlike hemifacial spasm, you never see, never see a vein is the main culprit vessel, the artery. But for sensory nerve, like trigeminal nerve, there is a case that it is compressed or adhered by the nerve, by the vein, But not sometimes there is no vessel, either artery or vein, but there is just arachnoid adhesion, makes the distortion of the axle of the nerve. So these are quite common in case of trigeminal neuralgia, but not in hemifacial spasm.
Okay. And my second question was, have you seen a persistent trigeminal artery as a culprit vessel for trigeminal neuralgia?
You mean persistent trigeminal artery?
Yeah.
Yeah. Maybe just in my series, I just suspected that there is one or two cases.
Yeah.
One or two cases. But during operation, we suspect that after operation, we make DSA, and and later on it's verified that there exists persistent
Okay.
germinal
And
artery.
suppose you don't find a culprit vessel, do you just compress the nerve with your forceps? Some people advise that if there is no offending vessel, like you told, sometimes it may be arachnoid adhesion, and there won't be any offending vessel, neither vein nor artery. In that even, do you just, some people tell that you just compress with your for bipolar forceps, just like that 2-3 compression, it will relieve, it will.
I think for the trigeminal neuralgia cases, it's much easier than hemifacial spasm.
Okay.
If in case of hemifacial spasm, if you do the wrong area, decompressing in the wrong area, that symptom will not go away. You know.
Okay. Okay.
But for trigeminal, if you there is a manipulation around the nerve with otherwise suction, with scratching, for example, with small incision, make any damage to the trigeminal nerve, the symptom will go away.
Okay. Yeah.
Maybe temporarily, you know.
Okay. It will
but
come back.
It may come back, but the symptom is immediate, you know. So I think, to my knowledge, trigeminal operation immediate effect is quite good. But if you not make a full decompression, you make the wrong place, and then the recurrence is high.
Yeah. Thank you. Thank you.
Thanks
Our
again.
follow
Question was,
long-term.
do you sacrifice petrocell vein? Do you ever sacrifice petrocell vein to?
Petrocell vein.
Yeah.
Petrocell vein is not sacrificed. Petrocell vein is not always the case.
Yeah.
In most cases, maybe in 80% or 90% operation, you don't have to sacrifice.
Yeah.
In very small case volume, the superior petrocell vein completely cover the artery or make the trigeminal nerve invisible, then you have to cut it. Okay.
Thanks, Professor Raja. I don't think you have much time for discussion.
Yes,
okay.
we can go.
Thanks, Professor Zhao, for your beautiful lecture. Raja, thank you again for the invitation. Whenever you need me, I'll be here to help with the ACNS. All the best for you too.
Thank you very much, Professor Hildo Azevedo and Professor Chow. That was a very wonderful session, and we had a great learning. Thank you, Professor Suresh Nair, for those wonderful comments and questions. Now we can go. Yes, Professor.
Thank you for your attention.
Thank you very much, both the speaker and chairs, for the first session. Now we can go on to Professor Kazuko Kurosumi to have his introduction part and invite Professor Liming. Professor Kurosumi.
Okay, so for second part, first, I am Professor Kazuko Kurosumi, Department of Neurosurgery from Hamamatsu University School of Medicine in Japan. Firstly, I would like to thank to Professor Kato and Dr. Raj for giving me the opportunity of for my chairperson. Immunotherapy for GBM has been challenged by its characteristic immunosuppressive tumor microenvironment in brain tumor area. Immunotherapies glioma are, for example, peptide vaccines and dendritic cell vaccines, chimeric antigen receptor T cells, checkpoint inhibitor therapy, oncolytic virus therapy, and gene therapy, so on. Especially today's talk is related to checkpoint inhibitor therapy. The phase 3 part of the Checkmate 143 trial, nivolumab versus bevacizumab in patients with recurrent GBM did not reveal significant survival benefit. However, recently, neoadjuvant use of anti-PD-1 antibodies increased overall survival. Today, Professor mainly will show inhibition of NAMP moderates the tumor immune microenvironment and acts cooperatively with anti-PD-1 checkpoint blockade. So I'm very looking forward to listening his lecture. Today's talk is entitled Immunotherapy in Gliomas. Professor Min, please start.
Thank you, everyone. Thank you, Professor Kazuko. Yeah, I will start my presentation. First, I introduce this work was done in Mass General Hospital Department of Neurosurgery. I finished my postdoc area in Mass General Hospital for nearly 3 years, supervised by Professor Daniel Kikio and Hiroaki Akimoto. I think maybe Professor Kazuko know Professor Hiroaki Akimoto.
Yes, of course.
Yeah,
I know him very well.
I think he's famous in Japan because he's an associate professor in Harvard. Yeah. So right now I'm a clinical neurosurgeon in China, but I will keep a close touch with them, with Mass General Neurosurgery Department. So today's presentation title is Local Targeting of Mvd Metabolism Changes the Tumor Immune Microenvironment and Enhance the Checkpoint Immunotherapy in Gbm. Actually, this paper has been published in the Cancer Research, has been published already in Cancer Research. So this is the outline of today's presentation. There includes the following parts. The first is background, the 6 parts and acknowledgement. First, I'll introduce the background. This is the workflow of the Mvd metabolism. From here, we can see if we block NAMP, the Mvd level will decrease and ATP will decrease, then cell will die. This paper was published by Japanese scholar Kan Tateishi. I think Professor Kazuko know him.
Yes,
yeah,
of course.
I think so. I think he's famous in Japan right now.
Yeah.
Yeah. So his paper showed if we block NAMP, the AD level will decrease, then ATP will decrease, then cell will die. So this is the background that what Kan Tateishi did in front of me. So in his paper, he showed that NAMP inhibitor, IDH wild type cell lines are resistant to the NAMP inhibitor, and IDH mutant cell lines are sensitive to the IDH, are sensitive to the NAMP inhibitor. He used the 2 models, MGG152 and HT1080. From here, we can see NAMP inhibitor can effectively extend the survival. However, there are some toxic if we use systematic treatment. How to overcome the systematic side effect? We try to use the local treatment. Local treatment, the drug release is one of the problem. So we look for another technology. This is the workflow that we want to use in the clinical in the future. Here, firstly, we use the biopsy to get the tissues, then test the IDH mutant, IDH status, then test the IDH wild type or mutant type, then resect the tumors. After resect, there's a tumor cavity. We can put the drug there. Then the drug can release slowly. So this is our plan that we wanted to transfer this drug into the clinical. This is our collaborator in the MIT, Professor Traverso. He made the particle for us. And we use his particles and test in 1 model, MGG152, and get some good data and publish in the PNAS 3 years ago. So in our previous work, we showed the NAMP inhibitor can can regulate tumor cells. How about, because in the tumor tissue, there's a lot of other cells, such as the macrophage, T cell, or other cells. My focus is about the other cells. So how does NAMD inhibitor modulate the immune microenvironment? This is a question that I will answer in my slides. First, part one, immune check the Gbm model selection. Most of the time we use 3 models. There's a 5 GL261 and GD2A. But which model is best? First, because checkpoint inhibitor is very important. So we use PD-L1 expression to determine which model we use. We don't want to those PD-L1 too low or too high. So finally we choose the GL261 model. Second, can NAMD inhibitor change the PD-L1 level on GBM cells? Because we choose the GL261 GBM cells, we first test the dose dependent. So we use a different doses, and we found with the dose increase, the AND level decrease, and the PD-L1 increase. We use two types of the NAMD inhibitor, FK866 and GMX1778. This data shows that NAMD inhibitor can induce AND duplication operated PD-L1 on most GL261 GBM cells. The second, we wanted to show, is there some time dependent? We found that with the time increase, we found the PD-L1 increase. That shows some time dependent. What's the pathway for this phenomenon? We try to increase the AND level. We use the AMN. AMN is a downstream of nicotinamide. And if we end the AMN, AND level will increase. We use flow cytometry. We found that if we end the AMN, PD-L1 level, will decrease. So we confirm that if we block NAMP, AND level will decrease and the PD-L1 will increase. So that's for most cell line. We try to use the human cell line. We use two human cell line, MGG23 and MGG119. We found there are some dose dependent, same as the most cell line. So conclusion, NAMP inhibitor upregulate PD-L1 expression on human and most GBM cells in vitro. PD-L1 expression treated with NAMP inhibitor have dose and time dependent. AMN can reverse PD-L1 expression and the AND level of GL261 treated with the NAMP inhibitors. Third part, can NAMP change the tumor immune microenvironment? So this is the vivo experiment. First, we look for the help from our MIT group, MIT collaborator. They made the new particles with the green color. This is Kumar-6 microparticles. We treated the mouse with this particle. We found that this particle can disperse in the tumor tissue. So we use these particles in vivo. First, we run one animal experiment. At the day 16, we treated with the mouse with this drug, and 4 days later we sacrifice the mice and we get a HC or F data. From here we can see PD-L1 expression increase in the NAMP inhibitor group. For further, we found that the most of the PD-L1 come from the nestin positive or ARG1 positive cells. And the GMX177 particles also can change the T cell infiltration. We use CD3, CD4, CD8. We found that CD3, CD4, CD8 increase in the NAMP inhibitor group. And we also found GMX particles can polarize the tumor-associated macrophage toward to M1 phenotype. We use 3 markers, CD68 and ENOS and ARG1. We found this particle can increase total macrophage and M1 macrophage and downregulated the M2 macrophage. So this part, we found that NAMPT inhibitor upregulate PD-L1 on GBM cells in vivo. And the NAMPT inhibitor also can increase the CD3, CD4, CD8 T cell infiltration. And the NAMPT inhibitor increases total macrophage and M1 macrophage and decreases M2 macrophage. So in third part, we know that NAMPT inhibitor can change the tumor-associated macrophage in vitro. So how about the vivo experiment? So we start a new experiment. In this experiment, we remove the tumor's tissue from the mouse brain, then dissociate, then counter, then plate. Then treated us with 6 hours later with different NAMPT inhibitor and a different time point, and do some staining. We found that this drug can decrease the tumor cells and decrease the M2 macrophage. So this part we found that NAMPT inhibitor not only kill tumor cells but also kill the tumor-associated macrophage in vitro. Because we found that NAMPT inhibitor can upregulate PD-L1. So how about the combination effect between the NAMPT inhibitor and the anti-PD-L1 antibody? Here we run the second animal experiment. This is the survival. We found if we combine NAMPT inhibitor with the anti-PD-L1 antibody, we found that this combination group can effectively extend the survival. And lucky there's one mouse was killed, and the body weight shows that there's no toxic effect. And IHC also shows that combination therapy lowers PD-L1 expression compared with the GMX177 alone. And the combination also changes the T cells infiltration. CD3, CD4, CD8, especially for the CD3 and the CD8, there's some significantly effect compared to the control group. And the combination therapy also can polarize macrophage marker, total macrophage, M1 and M2 macrophage. Under this part, we found the combination therapy can significantly increase the survival of GL261 model. Combination therapy increases CD3, CD8 T cell infiltration. Combination therapy increases total M1, total macrophage and M1 will decrease M2 macrophage compared to blank group. However, polarization of macrophage in combination therapy is similar to GMX177 alone. So the last part is the mechanism. What's the mechanism of PD-L1 upregulation on GBM cells? In previous paper, we showed the NAMPT inhibitor can decrease the ND level and induce autophagy. And here we show the NAMPT inhibitor decrease the ND level and upregulate the upregulated PD-L1. So we have the question: is there a connection between the autophagy and the PD-L1? So we have this hypothesis and try and to test. We use one autophagy inhibitor, 3-MA. From here, we can see autophagy inhibitor combined with the NAMPT inhibitor can rescue the autophagy. And we test the qPCR and the flow cytometry. We found that autophagy inhibitor can partly rescue the PD-L1, but not totally, not completely, just partly. So we think autophagy inhibitor can partly rescue PD-1. Autophagy maybe is a mechanism that underlines this upregulation. Final conclusion: NAMPA inhibitor upregulate PD-1 expression on GBM cells. NAMPA inhibitor increase CD3, CD4, CD8 T cell infiltration. Total and M1 macrophage will decrease M2 macrophage. And combined with NAMPA inhibitor with systematic anti-PD-1 antibody, significantly increase the survival of GBM models. As the last, we found maybe we think that the autophagy is the mechanism for this PD-L1 upregulation. So this is the lab that I worked in Harvard before. Yeah, thank you. Those PIs helped me for this finish this project. Thank you. Thank you for attention.
Thank you very much, Professor Kurosumi.
Yeah, thank you very much for your very great, nice talk. So I understand your our abstract is firstly so you chose cell line depend on PD-L1 expression. Then if you put that FK866 or GMX1778, those NAMP inhibitor, if you put that, the PD-L1 is up. Then those PD-L1, so NAMP inhibitor also induce CD3 or CD4, CD8 T cells upregulated, and instead NAMP inhibitor reduce the TAM expression. And so then you try to in vivo study, then you show the combination treatment
Yes.
in NAMP inhibitor and checkpoint inhibitor. Then finally you show the mechanism of this combination treatment. You think that is because autophagy induce those cytotoxic effect. So that's a very nice talk and very good result. Thank you very much.
Thank you very much. Professor Hilda would like to ask something, Professor Hilda.
Yeah, so now open papers. Yeah, please. Yes.
Thank you very much, Ling, for, if I call you Ling, for this beautiful talk, and also for your very important and then perhaps breakthrough research. My question is, how can your beautiful results in the lab could be translated into clinical work? Could you give us some clues?
Yes, actually we published some paper. We because this work we did this in the Harvard Medical School Mass General Hospital neurosurgery department. They did a NAMPA inhibitor. One of the group their work are focusing on the AND level. They published many papers about this. Right now, they are doing the clinical trial. Right now, they are doing clinical trial for NAMPA inhibitor in the GBM patients.
Any previous results about these clinical trials yet or not?
Right now, I think maybe next year we will know the result. Yeah, I think, and we miss. That's why we use this particle. We made this particle. That's just for translated in the clinical. This, I think, the clinical data will come soon next year. Yeah, we hope the results. Yeah.
Yes, my co-host, Dr. Liu Singh, any questions from your side?
Hello, Prof. May I know the delivery of immunotherapy? Which are the best route to give either direct injection or through bloodstream? Thank you, Prof.
This particle is just like this. In one of my slides, we found that we tried first because right now most MRI can test the 2-HG. If this GBM patients have the high 2-HG level, we know this is we know this is a IDH wild type or IDH mutant type. For if we have some of this, we can use after resection during operation, we can put the particles, nanoparticles in the tumor cavity in the operation. That will be translated because right now we combine with the MRI technology. 2-HG test, many MRI can test 2-HG. So we know if this has the IDH mutant, so we can put the drug in during the operation. But how to control this drug release? That's why we look for the help from the MIT group. They made this drug into the nanoparticles, so control the drug release. That's why our projects are very easy to clinical transfer into the clinical.
Thank you, Professor.
Thank you very much. I think if there are no further questions, we can have our concluding remarks from Professor Kurosumi.
So I have a couple of questions, okay?
Sure.
Okay.
Yeah. So you did the experiment for the glioma model. So is there any other cancers? Did you try that? Fibrosarcoma or other cancer model?
Yeah, I haven't tried, but you know, Kantadish, he tried in the sarcoma.
Oh,
Kantadish in the Yokohama City University, Yokohama, I think Kantadish.
Yeah, Yokohama, yeah.
Yeah. He did in the sarcoma model and published in the cancer cell.
Oh.
Yeah.
That's great.
I think right now he is also combines this namely inhibitor with a PARP inhibitor or other inhibitor. And Nagoshima, I think also doing in the Kobe University.
Oh, okay. Okay, and last question for me. So, so you did this experiment of COVID situation. So you are very hard, I think. So how was that situation when you experiment under the COVID situation? So,
sorry, can you speak that again?
So under the COVID-19 situation.
I see.
Yeah, so you are.
Yeah, actually, this project is project started at the 2018.
18.
So, 18 we started, and this I ran this for nearly 2 years. Basically, when the coronavirus came to this world, basically down my experiment. Yeah. So I'm some lucky.
So before the lockdown, so you came back to China.
Yeah,
so.
most of the data come out. Yeah.
Yeah. Some of my colleagues and so my friends are still working there. Then so very hard to work. So then now it's very recovered, but so in that COVID pandemic situation, they are very hard. They said that. So
right.
Yeah. Oh, okay. Thank you very much. Yeah, very good.
Thank you, Professor Kazuko. Yeah.
Thank you very much. We indeed had a wonderful session with Professor Ming Lee. I'll wind this webinar officially now on behalf of the Education Committee of the ACNS and the President, Professor Yuko Kaito. I would like to sincerely thank both the speakers of today, Professor Vigu Chow and Professor Liming, as well as the chairs, Professor Hildo Azevedo and Professor Kazuko Kurosumi, for the time and support for the ACNS webinars. A special thanks to our main mentor from China, Professor Shubin, who has arranged the WeChat broadcast for this webinar in China. And we are also broadcasting this on Zoom and YouTube. Currently, we have 1,530 neurosurgeons who are watching this live all across the world on various streaming platforms. So we are extremely thankful to Professor Shubin for that. A special thanks to my co-host, Dr. Liu Boon Seng, who has joined me today. Thank you very much, Liu. So until we all meet on next Wednesday, it is bye-bye from everybody. Thank you very much for joining.